All right, we'll make a start. It's after 12 now, so welcome everyone to teaching today from wherever you are. I wanted this talk is the second part of what we discussed last week, and we talked a lot about neonatal infections last week, and mostly we talked about neonatal sepsis, which is mostly suspected bacterial infections, but neonatal infection is much more than that. There's so many different types of newborn infections, and I think I can't tell you all about neonatal infection in just 2 hours. It's a huge topic, but I thought it would be worthwhile covering some of the other sorts of neonatal infections that are not just suspected serious bacterial infections like cord sepsis and pneumonia and skin sepsis and meningitis. Some of the other neonatal infections that are like congenital or intrauterine infections, they can be all put together. They're almost as common as as bacterial infections, but we don't always recognize them. So let's talk today about other sorts of infections besides bacterial infections. I said last week that the pediatric hospital reporting program, in that we should try to differentiate the type of infection that's there rather than just calling it neonatal sepsis, or we should try to differentiate whether a child's got pneumonia or meningitis or cord sepsis or skin sepsis. But there are also some other congenital infections that we really should be trying to identify and trying to monitor how common they are. These are a little harder, I think, to diagnose sometimes, but we should try to do that. So in the pediatric hospital reporting program, we try to monitor all of these other types of infections. The ones I wanted to talk about today, we briefly touched on it last week, are what used to be called, and sometimes still are called, the torch infections or the torches infections. I think it's an acronym that an abbreviation acronym that has some utility in that it helps us remember the common ones: toxoplasmosis, rubella, CMV, maybe herpes, and syphilis. But there's many other congenital infections that may be more common than those ones, and certainly cause a lot of morbidity in newborn babies and infants. And these include neonatal tetanus, which hopefully shouldn't be common, but like it still is seen; neonatal malaria or congenital malaria, which we'll talk a bit about today; parvovirus, that some of you will have heard about, but it's a relatively common cause of anemia and bone marrow aplasia in locations, especially where malaria is also common. And then enterovirus, which is very common, a common cause of infections in us all, but certainly a relatively common cause of infections in newborn babies, and that can sometimes cause myocarditis or meningitis or encephalitis. And then there's the Zika virus, which, as you all know, some years ago it emerged, and it was at that time a relatively common cause of microcephaly. But what we'll talk about today is how often these other forms of congenital intrauterine infections can also cause microcephaly. And then, of course, there's HIV, and I'm sure there's other congenital or intrauterine infections that I haven't touched on in this list, but many of them have relatively common presentations. Not all of them, but many of them present with multi-system disease that can affect the brain, causing microcephaly, can affect the eye, development of the eye, can affect the development of the ear and the hearing mechanisms, can affect the development of the heart. So some of these infections, particularly the earlier ones, toxoplasmosis, rubella, CMV, especially, are teratogenic infections, and in the earlier stages of development can substantially affect the development of a lot of vital organs. For other children, they'll cause inflammation and a sepsis-like condition, which we'll talk a bit about. So these intrauterine infections have many different manifestations, and it's very hard for us to identify one from another, but there are some general principles that apply to all or most of them. And I think I just want to go through the general principles of intrauterine infections. And firstly, at the bottom, we see clinical infective febrile illness in newborn babies, but in reality, these intrauterine infections cause a lot more morbidity and mortality than that. And so while a febrile neonate makes us think of a febrile neonate, or a newborn baby with a fever and a rash makes us think of some intrauterine infection, but there's a lot of other consequences of these infections affecting newborn babies and the fetus, including high rates of abortion or miscarriage, or stillbirth, high rates of stillbirth. Many of these infections cause preterm birth or intrauterine growth retardation. There are high rates of neonatal death and high rates of cerebral palsy and microcephaly. So to focus on just the febrile newborn baby ignores all the other consequences of these infections in neonates and in perinatal mortality. The other principles that apply to most of these infections, that even if you can't differentiate that one infection from another, there are some general principles. And one is that if a mother's not immune, then she's at much higher risk of transmission of the infection to the newborn baby. And that could be a febrile illness in the newborn period, or it could be the teratogenicity of these infections during pregnancy. So non-immune mothers with their first infections during pregnancy, whether it's from rubella or cytomegalovirus or varicella, one of the herpes viruses that I didn't mention specifically, but any of these teratogenic viruses, it's much worse if the mother is non-immune and has her first infection during pregnancy. Whereas immune mothers, but mothers who've been exposed to these viruses, which affects most of us at some stage in our lives, if they've been exposed to these viruses or if they've been vaccinated against these viruses, then they're at much lower risk of transmission. So that's just a general principle to understand. Often the maternal infection itself may not be apparent, although sometimes the mother's had a febrile illness or a respiratory viral infection or some diarrhea or whatever during pregnancy, but it may not be very evident that she's been unwell. But despite that, she can still pass it on to her baby, especially if it's a primary infection. The other general principle is that many of the features, as I showed in that diagram before, many of the features of rubella and cytomegalovirus and toxoplasmosis and herpes viruses, they overlap. And it's often very difficult to tell them apart, to make a distinction without doing special tests. Whereas those special tests are really complex. Sorry. Those special tests that you need to diagnose these congenital infections are actually, one, often not available, and two, they're complex and quite difficult to interpret. And difficult to interpret for many reasons, but I'll just tell you a few of them. And one is that most of us during our life will have been exposed to many of these viruses. So we'll have IgG, which is a normal antibody, and that'll be transferred from the mother to the newborn baby. The antibodies will be transferred. So a baby may be IgG positive, but it doesn't mean anything. It just means the IgGs probably come from the mother. If the baby's IgM positive, immunoglobulin M positive, then, as you know, that reflects a current infection or a new infection. And that has a high diagnostic value. It has what we call high specificity. That means if you're IgM positive, then you've probably got the infection. But the IgM takes time to develop, and so it has a low sensitivity. Most babies that present with these infections, they're not IgM positive at the time they present. And also IgM, measuring this IgM, this special serological test, is often not available. And so some of these infections like CMV and rubella require viral culture or PCR. So as I say, quite complex tests and complex to interpret. And so we fall back, therefore, on the clinical features of these infections. The last general principle of these infections is that mothers who are living with HIV have a higher risk of both infection and transmission. And if they have these infections, whether it's CMV or rubella, if they have these infections as primary infections or infections during pregnancy, or then they're actually also at higher risk of transmission of HIV as well as these other infections. So it's not uncommon for babies who are HIV exposed to be both have a risk of transmission of HIV, but also of CMV, particularly from a mother who has poor immunity, perhaps because she's got HIV and not got adequate immune reconstitution. So these are general principles relating to intrauterine infections that I think we can sort of learn. I want to go through a few of these infections now and just talk. As I say, it's not going to cover all the things that can be known about these infections, but the basics that you need to know. So this is a baby who has congenital rubella syndrome, and I'm sure that many of you have seen babies like this. This is, of course, a low birth weight baby. The baby has a cataract and glaucoma and has microcephaly. And so the features of congenital rubella syndrome, which is actually a relatively common condition, at least somewhere between 1 and 2 per 1,000 live births in almost all countries where this has been studied. The babies are born with congenital rubella syndrome. So that's one or two per 1,000 live births. If you think about perhaps 200 or 300,000 births in Papua New Guinea, then each year there might be 200 or 400 babies that are born with congenital rubella syndrome. It probably isn't less than that. And so if you take the prevalence in all other countries where this has been studied, then you can imagine there would be well over 100 or 200 babies born with congenital rubella syndrome each year. And some of them will be relatively less symptomatic, and some will be more symptomatic. These are the sort of conditions that are associated with congenital rubella syndrome. Again, it's one of the most, it's not the most, but it's one of the most common causes of hearing loss in older children having been born with congenital rubella syndrome. And children with CRS can have one or more of these manifestations. So they won't necessarily have all the manifestations. In fact, most of them don't. Some of them will just have 1 or 2 manifestations of congenital rubella syndrome. These are in large series, in large analyses of all the data on congenital rubella syndrome. These are the proportions or the percentages of complications that occur to children who are born with congenital rubella syndrome. So hearing impairment is the biggest one, 60%, congenital heart disease in 45%, microcephaly in just over a quarter, and eye problems like cataracts or pigmentary retinopathy that leads to blindness in about a quarter as well. So it's just worth knowing how common this is. So 1 to 2 per 1,000 live births. And of those babies, then many of them have these abnormalities. Cytomegalovirus is very similar in its manifestations to congenital rubella syndrome, but cytomegalovirus is probably even more common than rubella. Most people, by the time they reach adult life, have been exposed to cytomegalovirus and will have the antibodies to CMV. At some stage, we had a respiratory infection or we had a diarrheal-like illness, a gastrointestinal illness, and we acquired cytomegalovirus. And it often stays around. Like many of these viruses, it stays within your body. You have antibodies to it, you're protected, and you rarely get it again unless you get a different sort of strain. Even by 5 years, the studies suggest that 35% of all children have been exposed to CMV, have had a CMV infection. And it usually causes, as I said, a glandular fever-like illness or a flu-like illness. When we have the flu, it's often not influenza, it may be CMV. And it can make us just as unwell as the flu with respiratory symptoms, lethargy, rash, jaundice. We feel quite unwell for several days and then we get over it. Cytomegalovirus is a systemic virus, a bit like Epstein-Barr virus, a bit like the influenza, and it gets transmitted in all body fluids. So it's very common to transmit CMV from one person to another. Again, as I said, that general principle that if a mother's had CMV when she was a child, then she's not very likely to have a baby that's got congenital CMV infection. But if her first exposure to CMV occurs during pregnancy, then she's much more likely to transmit cytomegalovirus to her unborn baby. And but still, some mothers who've had CMV when they were children or adolescents can transmit it, and that's especially if they get infected with a different strain, because then they don't have as much immunity to that strain, and so therefore they're more likely to transmit the infection to their baby. Again, as I said, a general principle is that HIV is a risk factor for vertical transmission. So if a mother is living with HIV, then she's more likely to also have CMV, and she's more likely to pass on CMV to her baby. And unfortunately, if she's got coexistent CMV, she's also more likely to pass on HIV. But having said that, most congenital CMV is not related to HIV. So there's lots of babies that are born with congenital CMV, and the mother does not have HIV. It's something that happens even in people who are otherwise well, if they get a primary infection during pregnancy. The sorts of problems of congenital CMV are a bit like congenital rubella syndrome, but CMV is the most important cause of infective congenital hearing loss. Of all the infections that are likely to cause congenital hearing loss, congenital rubella syndrome and CMV. And then there's some other conditions, and this shows the ocular manifestations of a baby I looked after who had cytomegalovirus. And you can see that this is a retinoscopy, and you can see that there is extensive retinal hemorrhages. And so these babies often have what's called chorioretinitis, which is inflammation and hemorrhage into the retina, and they may well be blind as well as having hearing loss as well. This is another baby who had congenital CMV infection, and the characteristic feature, not characteristic, but the feature is this petechial rash throughout the body. This could be congenital rubella syndrome, because you can sometimes get a petechial rash like that as well, or it could be a bacterial infection that could cause a petechial rash, but it's typically with congenital rubella syndrome or congenital CMV. I mentioned before that microcephaly had been it really came to prominence during just before COVID, when Zika virus emerged, and there were many babies being born in many countries that had microcephaly. It was a sort of initially unknown outbreak of microcephaly, and then it became apparent that this was due to the Zika virus. But there are many other causes of congenital microcephaly, and I think it's worth, when we see a baby who's got microcephaly, then thinking that of course it could be congenital rubella syndrome if there's some other characteristic features like cardiac disease or microphthalmia, a very small eye, or it could be Zika virus, or it could be syphilis can cause microcephaly, CMV can certainly do it, and toxoplasmosis. So all of these intrauterine viral infections can cause microcephaly, but there's also other non-infectious causes of microcephaly, including genetic or chromosomal problems, or even toxin exposure. And increasingly, some toxins are being recognized as causing microcephaly. Certainly in some populations, then what's called fetal alcohol syndrome is a prominent cause of microcephaly. It's now called fetal alcohol spectrum disorder, and it's often leads to microcephaly and developmental delay. Other forms of drug use in the mother can lead to microcephaly. Mercury poisoning can, other teratogens, like if the mother's on phenytoin or some other teratogenic drug. So just be aware of a non-infectious non-genetic cause, such as a toxin exposure, if you see a baby who's got microcephaly. I want to now switch to, so we've talked about congenital rubella syndrome, we've talked about congenital CMV. I want to switch now to talk about another even more common congenital infection, and that is what these babies have. And I'm sure you'll be aware of this. These babies, you can see there's peeling of the skin on the feet and the hands and the arms. This baby has these necrotic patches on the soles of the feet. Is obviously a very low birth weight baby. This baby has a distended abdomen from a large liver and large spleen, and I'm sure you know that this is the manifestations of congenital syphilis, and the manifestations can be quite varied. So this is another baby with congenital syphilis. Sometimes you see a blister, a large bullous, as part of the manifestation, and sometimes you'll see sort of erythematous patches, red patches on the soles of the feet, or even these peeling necrotic lesions, peeling skin on the soles of the feet and the palms of the hands. So these are all the manifestations of congenital syphilis, at least the outward manifestations. But as I said, all of these congenital infections can carry consequences that are not just the clinical features in the newborn baby. They carry consequences of increased neonatal death or increased risk of stillbirth, other congenital abnormalities. And when we looked at this in Goroka many years back, Dr. Dale Frank studied 65 babies over a 2-year period who had congenital syphilis, and these were the clinical manifestations. Most of them had low birth weight or were preterm. Most of them had anemia. They almost always had hepatomegaly and splenomegaly. They often had ascites. Many had jaundice. Many had pneumonia. They had a syphilitic pneumonia, and many had periostitis, which is like like osteomyelitis related to syphilis, an inflammation of bone. The most important risk factor for mortality in these babies, many of these babies died, but the most important risk factor was low birth weight. If they were born at a normal birth weight, then their risk of mortality wasn't very high, but if they were born low birth weight, then their risk of mortality was extremely high. As you know, the treatment is, if the mother's symptomatic, if the mother's VDRL positive, but if the baby is asymptomatic, if they don't have any symptoms, but that includes not having low birth weight. If they're a normal birth weight without any of those other clinical features, without hepatosplenomegaly, or without jaundice, or without anemia, without a rash, without clinical skin manifestations, so they have to be completely free of symptoms and signs of congenital syphilis, then giving a dose of benzathine penicillin is sufficient. But many of these babies have more than just a VDRL positive mother, that many of them, the pictures I've shown you, they were all symptomatic in some way, and they need 10 days of benzyl penicillin, crystalline penicillin. If they don't get that, then they're likely to have ongoing infection that leads to further immune compromise and chronic infection during infancy and childhood. And certainly we have seen babies come back even at 1 or 2 years of age with secondary syphilis from being inadequately treated in the newborn period. And of course, you need to treat the mother. So it's just important to make that distinction between the baby who can be treated adequately with 1 dose of benzathine penicillin, compared with the newborn baby that needs 10 days of crystalline penicillin or benzyl penicillin. The two penicillins are different, but remember, if they've got any symptoms at all, then they need 10 days of treatment. I want to go on now to talk about neonatal tetanus. It's a little bit different to the other form of torches infections that I talked about before, but it's not unimportant. It's a very important condition that still, unfortunately, is being seen in some newborn babies. I think it's useful to know what the effective tetanus toxin is. Why does tetanus occur? And just to review the physiology at the neuromuscular junction, this is normal. This is what happens normally. So normally this is the nerve and this is the muscle, the cytoplasm of the muscle cell. And the muscle cell has acetylcholine receptors. And within the nerve are a lot of vesicles that contain acetylcholine. And if those vesicles release acetylcholine, then the muscle contracts. That's what's required for neuromuscular transmission and neuromuscular contraction. Now, if that happened in an unregulated way, if the vesicles kept if the vesicles were just released and caused uncontrolled contraction of the muscle cell, then we'd have no control over neuromuscular transmission. And the reason why we have control over neuromuscular transmission is that associated with every motor neuron, there are inhibitory interneurons that connect to the main motor neuron. And these have inhibitory neurotransmitters, especially like GABA and glycine. Now, if you remember back to the talk we did on epilepsy, GABA is one of the neurotransmitters that settles everything down. If you've got gamma-aminobutyric acid, it's a stabilizing, settling neurotransmitter. And so normally when GABA and glycine are released into the motor neuron, then that stops the release of acetylcholine. And so there's a regulatory effect of the of GABA on acetylcholine released at the neuromuscular junction. So therefore the muscles don't contract uncontrollably. But when you've got tetanus toxin available, then that blocks the release of glycine and GABA from the inhibitory interneurons, and then you just have uncontrolled release of acetylcholine into the cytoplasm, onto the receptors of the muscle cell, and then you just have uncontrolled muscle spasm or contraction. That's what happens when a child has tetanus. And the reason why it's worth understanding this is it helps you understand how long it takes for a baby to get better from neonatal tetanus. It takes as long as it takes for the tetanus toxin to be removed from the interneuron where it no longer has that effect. And that usually takes somewhere between 1 and 2 months. It can be as short as a few weeks, but it can be up to 2 or 3 months for the tetanus toxin to the effect of the tetanus toxin to wear off. And it also tells you something about why prevention works in these babies. Remember I said that when mothers are non-immune, then they're much more likely to transmit the infections to their babies. Most of us are not immune from tetanus. We've not been exposed to tetanus in our lives. We're only immune from tetanus if we've been vaccinated. The reason for that is because if you're exposed to tetanus toxin at all, then even the most minute quantity will cause clinical tetanus. It does that before it even causes an antibody response. So most of us, if we haven't had our tetanus vaccine, are completely unimmune to tetanus. And it's unlike with CMV and rubella, where we might have had an asymptomatic infection. You don't get asymptomatic tetanus infections. And so that's why immunization of mothers during pregnancy has been so important. And also tetanus vaccination in childhood is essential, because we wouldn't otherwise be immune to tetanus. Not like with CMV or even measles or rubella. We will be immune to it if we've been exposed to the virus. But with tetanus, we won't be immune unless we have been vaccinated. And so, as you know, that there's a recommendation for 2 doses of tetanus toxin, toxoid, 4 weeks apart during pregnancy. and in total, a total of 5 doses for the lifetime of the mother. And that's usually on top of having been adequately vaccinated in childhood. There's also prevention of tetanus also requires clean delivery and cord care practices. So if you're thinking about how to prevent tetanus, then there's those 3 things: clean delivery, clean cord practices, and tetanus toxoid in pregnancy. For the treatment of these babies, hopefully we don't have to treat too many babies, but sometimes it is necessary. And as I said, it sometimes takes 2 or 3 months for them to improve, but they can be treated adequately if you get all these things right. And usually it requires a combination of reducing unnecessary handling and noise, keeping them in a quiet environment, giving them oxygen if they have respiratory impairment, and then combinations of sedative agents and antispasmodic agents to reduce their risk of spasms. And it's usually diazepam orally and some paraldehyde sometimes, but usually it's best to sort of rely on diazepam or sometimes phenobarbital. They all need benzoyl penicillin, and ideally you could give the baby tetanus immunoglobulin. I know it's hard to get, but that would reduce the duration of the child's tetanus symptoms. And then usually nasogastric feeding, and sometimes magnesium sulfate can be useful. So it is possible to treat babies who've got neonatal tetanus and for them to recover okay, as these 2 babies that I showed you before did. That both these babies recovered quite well and are normal today, but it takes a lot. It takes a lot of effort over a month or so to get them to recover. And lastly, I wanted to talk about congenital malaria. So we've talked about CMV, we've talked about rubella, we've talked about microcephaly and the causes of that, and we've talked about neonatal tetanus. I wanted to talk about neonatal malaria because I think it's very interesting, and it's quite some of the risks are quite common, and that is that I think we see, if we looked in the blood film of many babies in malaria endemic areas, we might see quite a lot of malaria parasitemia. There was a study in Madang some years ago that suggested that malaria parasitemia in blood films were quite common, but I think it's not that many babies get clinical manifestations. It's actually quite rare to get clinical manifestations. A definition of congenital malaria is any malarial parasites in the peripheral blood or in the umbilical cord blood in the first 7 days of life. If you sample the umbilical cord blood, then sometimes you get some maternal blood in the umbilical cord blood. So that's not necessarily congenital malaria. But if the malarial parasites are also in the peripheral blood, then in the first 7 days of life, then that's the definition of congenital malaria. Now, most cases of congenital malaria, that the clinical manifestations again apply where the mother contracts malaria in pregnancy for the first time, when the mother's not immune. And it's more common in primogravid mothers than it is in multigravid mothers. That is the clinical manifestations of it. Usually, if congenital malaria is causing clinical features, then it will be associated with placental malaria. So if you sample the placenta, you'll find malarial parasites in the blood of the placenta. But again, it's important to know that even though maternal malaria might be very common, clinical manifestations of malaria are actually quite rare. Maybe 0.3% of all mothers that have been that are infected during pregnancy, their babies will get malaria. It's more common depending on how you test, and I'll explain that in a little while. But mothers who are first-time mothers are more likely to pass on congenital malaria to their babies. But those that do, the clinical manifestations tend not to occur until after a week of age. Like, it's usually between 10 and 30 days. So when you see a baby in the first few days of life and they've got some malarial parasites, they may or may not be the cause of their baby's fever. There might be some other cause of the fever. And the reason for that is that usually the malaria parasites don't only replicate in reticulocytes, that is the immature red cells, and immediately after birth, there's fetal hemoglobin around, so the bone marrow is actually not making new reticulocytes, so there's no mechanism for the malarial parasites to replicate. Also, mostly the mother's antibodies will suppress the symptoms, suppress the infection in the baby. And that's why even if a mother's has malaria during pregnancy and at the time of delivery, malaria manifesting in the baby is not very common. It does occur, but it's not very common. But when it occurs, there are three features. There are three things that almost always occur. One is fever, one is anemia, and one is splenomegaly. In all the series of congenital malaria, the clinical features, 100% of babies have fever, anemia, and splenomegaly. There are some other features that are sometimes seen, so hepatomegaly or jaundice, vomiting and diarrhea, poor feeding, respiratory symptoms like the febrile unwell neonate. So if you see a febrile unwell neonate, then look to see if they've got anemia or splenomegaly, and then you should think that they might have congenital malaria. One of the reasons why malaria in pregnancy is interesting is that it's a different form of the parasite that causes the infection, and it's what's called a CSA form, a chondroitin sulfate A binding form of the parasite, and there's chondroitin sulfate A antigen in the placenta, and the malarial parasites bind to that, and that's why not all malarial parasites will actually cause malaria, although falciparum malaria, vivax malaria, ovale malaria will, but not the standard form of the parasite. And so mothers not only need to be immune to malaria in general, but also need to have been exposed to this chondroitin sulfate A CSA binding form of the parasite. So if a mother is immune, they come from a highly endemic area, then transmission of disease is extremely rare because they've got antibodies, they get transmitted to the baby, and the baby doesn't get unwell. If they're semi-immune, that is, they might have some antibodies, they might have been exposed at some time, but not a strong antibody response, then often the mother, if they get malaria during pregnancy, will have severe anemia, and their baby might have low birth weight, and be at some risk of congenital malaria. The babies that are most at risk of infection are those where there's a mother who's not immune. And as I said, two things influence whether a baby gets congenital malaria. One is the mother's immunity, and the other is the gravidity of the mother. That is, if the mother's got maternal antibodies to CSA binding parasites that build up over several pregnancies, then she's very unlikely to transmit malaria. But if it's a primary gravida who gets infected with malaria and is not immune, then there's an increased risk. In some ways, the prevalence depends on how you make the diagnosis, and this is important because in the past, we always made the diagnosis with just a light microscope, just looking at a blood film of the baby. And it's very rare in highly immune mothers. But when you do a PCR test on cord blood or on the baby's blood, then the PCR is a bit more likely to be positive if the mother is malaria positive, P. falciparum positive. And probably that reflects that PCR is a bit more sensitive than the light microscope, but it also reflects that sometimes there'll be maternal blood contamination. So the transmission of malaria from an infected mother to the baby is still quite rare, I think. What's important to know is that you shouldn't use rapid diagnostic test to rule out neonatal malaria. There's been some studies done recently to suggest that there's actually quite low sensitivity. And so just because of, even if the baby is positive on light microscope, then the RDT is likely to be negative. So it's not the rapid diagnostic test in neonates is not a very good test. Very good outside the neonatal period, highly specific and sensitive, but not in newborn babies. And there could be a variety of reasons for that. One being just very low parasitemia, low level parasitemia, that not sufficient for the RDT to pick it up. And as I said about all of these viruses, that there is an interaction between maternal HIV and malaria. And certainly if a mother has HIV, then she's likely to have a higher density of placental malaria parasitemia, because CD4 cells are quite important in the immunity to malaria. And she's more likely to have a baby that's got low birth weight and anemia. And it may even, like CMV, increase the risk of maternal mother-to-child HIV transmission. And there's good evidence from African studies that it increases the maternal viral load if there's coexistent malaria and HIV. 1 to 4-fold higher maternal viral load, so therefore an increased risk of transmission during pregnancy. So just like all of these intrauterine viruses, you can understand that if a mother has HIV, then that she has a greater risk of transmitting the virus. That's not so if the mother's HIV is treated and she's got good immune reconstitution and she's got viral load suppression. So it's important to ensure that occurs. The treatment for neonatal malaria is for falciparum malaria artesunate, or in some countries quinine plus clindamycin is given. Quinine, of course, is more likely to cause hypoglycemia, so better to use artesunate. Not many studies have been done in neonates using artesunate, but a few studies have been done suggesting it's relatively safe. And with Vivax malaria, then artesunate again, or in some countries are using chloroquine for neonatal malaria. One important thing about neonatal malaria and Vivax malaria is you don't need to give primaquine, as the malarial form that's transmitted is not the liver stage, it's only the blood stage. And so you only need to use artesunate, not primaquine, which is good because you need to be testing for G6PD before you use primaquine. But if the mother has Vivax malaria or Plasmodium ovale, then it's important that she should have primaquine so that she doesn't have chronic malaria as long as she's G6PD negative. So I won't talk too much more, although as I've said, there's so much more that could be said about these newborn congenital infections. But I hope I've just given you an overview of these infections, both the torch infections that we sort of think about, toxoplasmosis, rubella, CMV, herpes, and syphilis more commonly, but also the other infections that in some ways are important causes of neonatal morbidity and mortality, like tetanus or malaria. And I mentioned parvovirus, quite common in PNG, enterovirus, more common than you realize, Zika virus causing microcephaly, and of course HIV. So that's just an overview, but I wanted to try to explain how important newborn infections are and how we need to differentiate between just neonatal sepsis and what a specific infection is present. So I'm going to stop talking now. I'm going to stop, turn the recording off.